Hello everyone, today we'll be talking about anion gap and what causes this, and we'll understand some basic principles behind this. In reality, there is no anion gap. The sum of anions equals sum of cations, and these are the list of anions and cations present in your serum. In the past, when people measured the anions and cations in the serum, they found sodium, bicarb and chloride, and they always found a gap between the sum of positive ions and negative ions, which they called anion gap, and they found it to be useful in figuring out certain acid-base disorders. Now we know there are multiple other positive and negative ions present in your serum, but we still use anion gap, and the way we define it is the difference between positive measured ion, which is sodium, and negative measured ions, which are chloride and bicarb. Normal range is 8 to 12. Some physicians will add potassium to the mix as well, but classically this has not been used, so we will omit in our discussion. But if you want to go ahead and use potassium in your equation, the normal range would be 3 to 4 levels lower. So what causes increase in anion gap? Let's add an acid, say lactic acid, to the mix. The H plus ion from the lactate is going to combine with the bicarb ion from your serum to form carbon dioxide, which is going to be excreted out. The lactate ion is going to remain inside. That lactate ion is going to increase your anion gap by the same amount that you lost your bicarb. If you got higher levels of lactate, there will be more H plus ion and more bicarb will be used, more CO2 will be excreted out, and your anion gap will increase further. There is 1-to-1 relation between these two. If you add 1 milliequivalent of acid, you will use 1 milliequivalent of bicarb. There are a lot of mnemonics out there, like mud piles and cat mud piles, but gold mark seems to be more clinically useful. These include glycols, oxaproline, levolactate, dextrolactate, methanol, aspirin, renal failure, and ketones. Lactate is the most common ion that gives you an anion gap. Most of us know that lactate is produced by impaired tissue oxygenation, but multiple times you will have lactic acid formation even if there is no impairment in oxygen. For example, drugs like metformin, diabetic ketoacidosis, malignancies, alcoholism, liver disease, etc. If you remember, lactic acid has two isomers, levo and dextro forms. The dextro form is produced by the bacteria and is produced in patients with jejunal-ileal bypass and short bowel syndrome. This unfortunately is not measured during your regular lactic acid levels. So in these patients, you can still have an anion gap, but normal looking lactate levels. Acetoacetate, acetone and beta-hydroxybutyrate are the three ketones. Urine ketone uses nitroprusside test, which tests for acetoacetate and acetone, but beta-hydroxybutyrate, the nitroprusside test is negative. So urine ketones cannot catch beta-hydroxybutyrate. So you use serum level to check for this. Acetoacetate is made when there is too much acetyl coenzyme A, and this happens under two circumstances: ethanol ingestion and fat breakdown. Fat breakdown is seen in two conditions: diabetic ketoacidosis and starvation. The ratio of acetoacetate to beta-hydroxy depends upon the NAD to NADH ratio, which is normally 1:3. In patients with ethanol and decay, there is excess of NADH, so it drives the reaction towards beta-hydroxybutyrate. However, in starvation, there is NADH, but it's continuously being used towards energy generation. So you'll have more acetoacetate than beta-hydroxy in starvation. Acetone is formed by the non-enzymatic decarboxylation of acetoacetate. It's also produced excessively in isopropyl alcohol poisoning, which is your rubbing alcohol. Acetone is a neutral molecule and does not cause an anion gap. And these patients with ethanol ingestion and fat breakdown can have fruity smell because of acetone. Another reason for anion gap is glutathione synthetase deficiency, which results in accumulation of pyroglutamic acid. Since you use glutathione synthetase to make glutathione, which is used for metabolizing drugs like Tylenol or acetaminophen, these patients can become acidotic if they take Tylenol. Anion gap can also be seen as the difference between the unmeasured anions and unmeasured cations. And this can help you understand some of the other causes for increased or decreased anion gap. So you can have increased anion gap if you have low levels of unmeasured cations like potassium, calcium, magnesium. However, this is not much as these levels are very low. You can also have elevated anion gap if you have increased unmeasured anions like albumin, phosphate, sulfate, and sometimes this can be seen in renal failure, or if the patient is dehydrated, your albumin can be relatively higher. But these do not increase the anion gap by much. What about the low anion gap? If you have decreased unmeasured anions or increased unmeasured cations, you can have lower anion gaps. Since albumin is the biggest contributor to anion gap, hypoalbuminemia is the commonest cause for low anion gap. So there is an albumin correction factor 2.5 drop in anion gap per 1 gram DL fall in albumin. And the way to remember it is your normal anion gap is 12 and your albumin levels are around 4. So it results in around 3 per 1 gram per DL fall in albumin. However, since there are some positive ions as well, it is slightly lower than 3, that is 2.5. Low albumin is observed in liver disease, nephrotic syndrome, malnutrition, and critical care illness, as it is a negative acute phase reactant. Increase in unmeasured cations can also lower your anion gap, and this is mostly seen in elevated gamma globulins. However, it can also be seen in hypercalcemia, hypermagnesemia, hyperkalemia, and most importantly, lithium toxicity. So the most important step is correcting for albumin. If everything else looks okay, think about gammopathy, and this can be monoclonal or polyclonal. And as you can see on electrophoresis, you will see a single spike if it is monoclonal, and this is seen in cancers like multiple myeloma, while polyclonal gammopathy is inflammatory, seen in infection, HIV, etc. And the way to figure these things out is looking at your albumin to globulin ratio. Normal AG ratio is 2:1, and it's inverted if there are more globulins, where AG ratio becomes 1:2. Your total proteins are albumin plus globulin. A lot of lab tests don't give you globulin levels. However, you can figure that out by subtracting albumin from total proteins. If your lab uses flame photometry, you may not be able to catch pseudohyponatremia in patients with hyperlipidemia or hyperproteinemia, and this would falsely decrease anion gap. So if you suspect this, use your blood gas analyzer, which uses direct potentiometry and will give you more accurate values. Low anion gap can also be seen in pseudohyperchloremia, and the common cause for this used to be bromine and iodine overdoses, and these can interfere with the chloride measurements. Recently, pseudohyperchloremia can also be seen in salicylate toxicity if measured by chloride ion sensitive sensing electrode, and this can give you falsely low anion gap with salicylate poisoning as well. So in summary, anion gap is difference between measured cation, that is sodium, and measured anion, that is chloride and bicarb. If anion gap is increased, you always have a metabolic acidosis. Always correct for albumin. Anion gap decreases by 2.5 per 1 gram per DL fall in albumin. For increase in anion gap, remember gold mark. Try to figure out where anion gap is coming from. For decrease in anion gap, think about monoclonal gammopathy, lithium toxicity, and other errors that can result in low anion gap, which are lab errors, pseudohyponatremia, and pseudohyperchloremia. Thank you.